This meeting is being
There we
recorded.
go. There we go. All right. So welcome everybody, zebras alike. My name's Christie Cox, and today we're here with the EDS Empower Hour celebrating Invisible Illness Awareness Week. And we've got a couple of great guests with us tonight, and we're going to talk about the struggles and challenges and some tips for disability related issues when you have Ehlers-Danlos syndrome or connective tissue disorders. And the first order of business is I've put in the chat a link to an anonymous poll that we're going to show the results here in just a moment so that we have an idea of the people that are on the call live with us today, what their status is and whether they're working or on disability, so our speakers will know. While you're taking that poll, I'm going to introduce our speakers. Dr. Eric Singman is with us from the University of Maryland, and he's a neuro-ophthalmologist and a real EDS advocate. Looking forward to hearing from him. Dr. Rodas, who is a national disability advocate for people with Marfan's and connective tissue disorders, is unfortunately not able to make it because he's in the hospital. And so let's send our good thoughts to him. And then our other guest is Bresnahan, and she is from a law firm that is going to talk about some of the appeals process with long-term disability. I have some Q&A that I'm going to go through after everybody introduces themselves. So first, I'd like to kick off and invite Dr. Singman to give himself a quick intro, if you would, and then we'll go to Ellen and we'll get started. All right, looking good.
Hi, everybody. Can you hear me?
Yes.
Great. My name is Eric Singman. Please feel free to call me Eric. I'm a neuro-ophthalmologist. I've been in practice about 25 years. And my introduction to the Ehlers Danlos community was kind of through a side door, if you will. I had a patient with Chiari malformation who was having some difficulties and not doing well. And despite the fact having Chiari surgery, there were still problems going on. And I just try to help patients if I can. And we worked together, and it turned out that she had Ehlers Danlos syndrome. So I said, you know something, I really need to know more about this, partly because what they teach us in school about Ehlers Danlos in med school was quite limited. Back when I was in med school, there was not 13 kinds of Ehlers Danlos. First of all, genetics was not really there. I mean, genes were Levi's, okay? So it just wasn't there. And so I started getting more and more into working with patients who had neurologic problems and finding out that, hey, guess what? A lot of the neurologic problems that I had to deal with, whether it was Chiari malformation, whether it was intracranial hypertension or hypotension, whether it was migraine, these patients Ehlers Danlos patients were popping up. And so we started looking more carefully at them. We started documenting the patients. Fortunately, at Hopkins, we had EPIC, which was a good medical record system allowing us to plumb its depths and look for patients who had it. And we started noticing patterns, like Ehlers Danlos patients had concussions that weren't getting better compared to other concussion patients. We actually published a small series on that. The hardest part of that series, as you can imagine, was when we suspected Ehlers Danlos. There was no way I was going to diagnose that condition. I'm an ophthalmologist, for goodness sake. So I sent them to geneticists. And so I first, of course, did the obvious thing and tried to send them to the Hopkins geneticist. And they wrote me a letter saying, don't send us your Ehlers Danlos patient if they're over 21, because we can't do anything for them. And so I was a smart butt, and I said, well, what would you do for them if they were under 21? But the better part of me didn't send the letter. I canceled that email. I was this close. But it's like, guys, I need you to these patients need to know. So I finally was able to get 7 into geneticists all over the country. We have now about 50 patients who we diagnosed with Ehlers Danlos because their concussion symptoms weren't improving. So that's kind of how I got involved. And then I got more involved recognizing that there was some misinformation about Ehlers Danlos. For example, there was a caveat that all Ehlers Danlos patients, you have to look for something called angioid streaks in the retina. We never found any, ever, in 400 patients. And it turns out that everyone was quoting one paper that came from Hopkins, in fact, by a geneticist who looked at a family that had Ehlers Danlos as well as pseudoxanthoma granula and elasticum. And so it turns out that all the references about that came from one paper on one family in two patients. And now we have 400 patients. And then Moorfields Eye Hospital confirmed that. So as I said, I kind of got into Ehlers Danlos through a side door, but because many Ehlers Danlos patients so often have concussion, and because Ehlers Danlos patients often don't even know they had a concussion because they're more fragile, that's when I started seeing more and more of these patients. And then, of course, the Chiari patients, then it just steamrolled because the Ehlers Danlos patient said, hey, there's a doctor here that doesn't make me feel like I'm a moron. and you know, so apparently that's a rare thing, which is sad to me. But, I mean, these are people. And as a doctor who deals with concussion, I know that invisible hurt is real. And I think maybe more doctors need to know that. But again, that's probably the hallmark of Ehlers Danlos, that it's often invisible hurt. Anyway, that's my spiel of why I'm here.
Oh, great. Thank you for joining us. Ellen, how about if I hand it over to you for a quick intro?
Sure. Thank you, Christie. I'm Ellen Bresnahan. I work with Ben Glass Law in Fairfax, Virginia. And we represent clients who primarily have group disability insurance through their employers. Some have individual disability insurance that they purchase themselves, but mostly it's through the employers. And you know, Ben's been doing this for 20 something years, and in the past 6 years or so, when I came on board, you know, we've really tried to grow the practice area. And now we're the largest filer of disability appeals and litigation in Virginia, and probably one of the largest in Maryland too. So we have several clients on claim who have Ehlers-Danlos syndrome, and we get denial letters. Our pitch to the community is that we'll review any denial letter that you get from any disability insurance company for free, and we'll tell you, here's why we think they denied your claim. If you've ever gotten one of these letters, you know they're 6 to 8 pages long. They go through all the history of your medical records. It's very, very hard to figure out, what's just information they're passing back to you and what's their actual analysis and the reason why they denied your claim. So we try to help people figure that out, and then we try to give them some guidance for here's what you need to do if you want to appeal this decision to deny your benefits. And as you can imagine, and I'm sure that a lot of you have personal experience with, a lot of claims for this disability that arose out of Ehlers-Danlos syndrome are denied. And it's the kind of disability where people have trouble proving because most people who have this condition are not disabled. They find a way to keep working. Probably most of our clients for years found a way to keep working as their condition declined. So it becomes a question of trying to convince the insurance company, why you could work Friday, but you can't work on Monday. And you need some time now to see if you're going to be able to regain your functional capacity. And the insurance company does not really care what your explanation is. They want to hear from your doctors. And that loops right back to what Dr. Singman was just talking about. A lot of doctors are not supportive of these claims. So we try to talk about, how to document your symptoms and the impact that your symptoms will have on your functional ability to work, rather than just focusing on a diagnosis. Yeah. So, yeah, that's sort of the angle that we're coming from.
All right. Well, if everybody will allow, I'm going to share my screen just for a moment and kind of show what everyone's saying in terms of the where they are. And if you can see my screen, shows that a lot of people are still working, or they're not working and they're not on disability. A little bit of people are on Social Security. or other. So, that's encouraging. Um, we'll come back in a moment and do another poll. But one of the things that I wanted to have the opportunity to talk about today is the recent report that Dr. Singman participated as a committee member that came out from the NAS, where they did a wonderful job outlining the medical rationale behind what keeps an EDS patient from functioning optimally. Eric, can you tell us a little bit about that process of being on that committee and
Sure.
the findings?
Happy to, absolutely. First, let me just second what Ms. Bresnahan said. From what I've seen, disability seems to want you to be basically at least 14 hours dead before they offer you disability. And if you can't prove that, then you have a problem. I've never seen, I think that they have a process where they simply send back your request the first time automatically, and then they just, to see if you're really interested. But you would think that doctors and lawyers don't mix well. But I tell you that in my experience, the Ehlers Danlos patients I've had and the concussion patients I've had, if they didn't have a disability lawyer helping them get it, they just would be stonewalled. At any rate, 2.5 years ago, Social Security Disability was saying, we're getting bombarded with disability claims from people who say they have Ehlers Danlos. And we realized we don't really know what the heck this Ehlers Danlos is or who this Ehlers is. Maybe his cousin Danlos will tell us something. We don't know. So they said, let's do what we do when we have this situation. And they go to the National Academy of Science, Engineering, and Medicine. Used to be called the National Academy of Medicine. Now it's NASEM. And they said, can you do what you've done to us for us in the past? Put together a select committee and write a book. And make sure the book gets peer reviewed by people who you trust and who are good. And then if we like it, we'll accept it and we'll go by that book. And so they put the committee together. I was asked to be on it. Honestly, some of the people on the committee were some of the biggest people in Ehlers Danlos in the country. I said it before, I'll say it again. I felt like a turkey flying with eagles. I mean, these people were amazing. We worked on, in a very careful format, listing out all the different systems that would be involved in disabling problems, listing out therapies that might be available or not available, listing out rehabilitation strategies that may be available or not available, listing out the kind of disabilities that the patients might describe. And it was with a very strong advocate background that we put this together so that the benefit of the doubt kept going towards the patient. And this was peer reviewed, and this was accepted by Social Security Disability. So now they have to follow it. They have to follow it.
Everybody give it the heart, right?
So,
everybody give it the heart.
So they have to follow. It's their book. They got to follow it. So they've said, great, we got that. So if you can point to something in that book, okay, what are they going to say? No, sorry, it's in your book. So that's where the book was written. Believe it or not, the book was written for Ms. Bresnahan. Yes, it was written for the doctors who treat Ehlers Danlos patients. Yes, it was written for the patient's family so they could validate the patient's illness, so the patients stop feeling like they're hypochondriacs. Yes, it was written for those people, but it was written for Ms. Bresnahan, so when she goes to the book and she goes to the Ehlers Danlos patient, because how many Ehlers Danlos patients don't have a full awareness of their illness? Somebody has some neck problems. They all have neck problems. I mean, let's be honest. And someone's focusing on the neck problems, and they might not think, they might not be aware of something called mast cell problems. They might not. We have gastroparesis. Oh no, I've always had irritable bowel syndrome. That's not related to my Ehlers Danlos. No. Wait a second. So what was nice is that the Ehlers Danlos patients themselves can become more aware of illness, but also they can sit down with their disability attorney or their disability advocate, whoever that might be, and say, let's go through this. Let's find out who you are. Don't be afraid. List everything you have, and let's see if we can find it in the book. chances are you will. And that will give you, because what happens with disability is that, same thing with concussion patients. There's observed disability, there's some more of a hidden disability. If you don't list all the things that are reducing your quality of life, your ability to work, your ability to function, you're tying your hands behind your back, because if you don't list that stuff, how are they going to know? How is Social Security going to know? I mean, and I assure you, I've had two patients now. I don't know if this is a new thing or not, but I have two patients now where they were recorded doing stuff by a private investigator. One was walking their dog, the other was sitting on a beach and reading a book. And that was proof that they're fine. Are you kidding me? So you need to be actually that much more careful. No, you don't have to worry about a drone watching you, seeing your every move, perhaps, yet. But people have to understand that there's disability and there's disability. Just because you can walk your dog doesn't mean you can work at Amazon on a production line all day long. There's a difference, And so this is where the book becomes so valuable, and it's free. I mean, your tax. Well, I mean, it's not free. Your tax is paid for it. We didn't get paid, by the way, so we volunteered. So that part was free. But the hardcover is $35 and the download's free otherwise. I urge everyone to please get it, look through it. Even if you have Ehlers Danlos and you think you know all about your illness, I urge you to look through it just to see, wait a second, you might get some insights on things you might not have connected. It really was a comprehensive work by a comprehensive team.
Absolutely. I mean, it's a tough read, it's dense, full of medical information. But, when you can sort of chop it down and you recognize that they're talking about it by kind of like system in the body. And so it's like there's like cardiovascular considerations and, other considerations. It's really quite validating and quite rich. And I've put a link in the chat to the report so everyone can get it. And I'm also putting a link to common disability terms, just legal terms, so that hopefully that will help everybody get, kind of acclimated with that information. And it is groundbreaking research that Dr. Singman and the other esteemed panelists put together. And, thank you, all of our gratitude for the work that you've done to support our community. So Dr. Singman and or Ellen, what recommendations do you have for patients, that might be considering going on disability, or they're considering filing for disability, or, what kinds of things do they need to document, or evidence they need to gather, or journal? Do you have any ideas on that?
Sure. I think in general, you touched on one of the problems for disability when you talked about all the different types of symptoms and associated specialists is the issue for disability. When you make a claim and you say, I have all these symptoms that are disabling, the insurance company wants to know, well, who's seeing you for that? And they have their boxes of, you have joint issues, you need to be seeing a rheumatologist. You have, POTS or some kind of orthostatic autonomic nervous system disorder, you need to be seeing a cardiologist for that. You have neurological symptoms or ophthalmological symptoms, you need to be seeing a neuro-ophthalmologist. So the list obviously can get very long. You have gastroparesis, you need to be seeing a gastroenterologist. And for a lot of patients, the idea of finding one doctor who's supportive and understands your condition, is pretty amazing. The idea that you're going to have a whole team is really very, very hard to comprehend. Very few people have that luxury. So as you're thinking about making a claim, and ironically, the claims where you don't have time to think about it, those are usually the ones that are easiest to get approved, because something happened. You got in a car accident, you had a bad fall, something easily identifiable testable, ideally treatable, so that the insurance company feels like they're not going to be on the hook for a young person who's going to be on disability until retirement age potentially. But if you don't have that easily identifiable, this was the thing that happened, don't stop working and then figure it out. You have to try to figure it out while you are still working, because your disability policy normally will only cover you while you are actively at work. Once you stop working, that's when you stop having coverage. And if you want to be approved for disability benefits, you need to prove that you were disabled as you stopped working. So if you don't have that supportive medical team in place before you stop working, it's very hard to reconstruct after the fact. So ideally you're thinking about, how is this going to look to the insurance company as you lead up to making a claim? Are you going to be able to explain to them through your medical records? Because that's the only language they understand. They don't really understand. They don't want to understand what you're telling them. They want to see what your records say. Through your doctors, are you explaining why your ability to function at work is declining? And that's going to be a combination of, what are your work responsibilities? Are you a stalker at Amazon and it's a physically demanding job, and it's just too hard on your body? Do you have a sedentary job, but it's very cognitively demanding? And a lot of times the gastroparesis can interfere with sedentary jobs, because, obviously you cannot sit and focus and concentrate for long enough to be productive at work. So we kind of advise people to, make a list of the symptoms that are, these are the top, 2, 3, 4 things that are preventing me from working right now. And then make sure that you have a doctor, more than one is ideal, but at least one doctor who will help walk the insurance company through, what's going on with you in your medical records. I have noticed Christie XYZ, she's had these tests. Here's our treatment plan. Because again, remember, insurance companies always like to see that there's a hope that you're going to, get better and improve, and they won't be on the hook for this claim until retirement age. And here's her prognosis. Like, we're gonna revisit. Here's our treatment plan for the next 6 months. Then we're gonna revisit it and see how her functional capacity is. So the more that you can sort of think about that and get that lined up before you stop working, the better the chances are that your claim is going to be approved. That said, Dr. Singman is, absolutely 100% correct. We see a lot of these just sort of rubber stamped, not supported, a claim denied, and then, the terrible irony of that is that then you're forced to go and get an attorney. We have in our literature to potential clients, we quote all the judges who say anybody who's trying to do an appeal like this on their own, they don't stand a chance. And it's because of the things that Eric talked about. The insurance company has surveillance. They have their stable of well-paid medical experts who, sometimes I wonder, like, how do you people sleep at night, doing these reviews on records for people you've never met, who are, are clearly having a very difficult time. And I think, saying that they're not disabled, the insurance company really tries to shield their reviewing doctors from feeling like they're on the hook for making this determination, because they just ask their doctors to talk about what your functional limitations are. And if the doctors can't see them in your medical records, they feel fine telling the insurance company, yeah, no restrictions are documented in the records. So, I don't think that she has any. And then that's enough. They'll say, oh, your claim is not supported, benefits denied. So yeah, it can be uphill battle, and the more that you think about it and prepare for it in advance, the better off you're going to be.
Yeah,
that's a wonderful summary, and I agree with it completely. There are some things that you can do to help yourself. First of all, as Ellen said, let's say how many patients have horrible necks, but a plain old MRI showed nothing. MRI showed nothing. How bad could your neck be? So there are certain tests that might make it easier to demonstrate things like cervical instability and such, like upright MRIs, but a lot of doctors don't know about them. So as Ellen said, you want to have a team. Now, there are some centers of excellence, like where Claire Francomano is building out in Indiana, where there are things you can get a lot of stuff under one roof. However, that's rare, as Ellen suggested. My approach to it is if you can get a doctor who's an advocate for you, that doctor, even if they're not Ehlers Danlos aware, would be willing to learn about Ehlers Danlos. Now you have a book to show them, in fact. Let them learn about Ehlers Danlos. Let her learn about Ehlers Danlos. Let them say, okay, wait a second, I get it now. I'll be your advocate and try to find you other doctors and help you get the team. I've tried to develop a network of doctors I work with. When I was at Hopkins, now that I'm not there, it's much more difficult, especially because Hopkins is not taking Blue Cross Blue Shield care first anymore soon. And so that's going to be a huge rent for a lot of patients. So I'm only been at University of Maryland about a year or so, and so I'm trying to develop another network again, which is slow to happen. The geneticists have been much more responsive. They say, we will see your Ehlers Danlos patients, but there's a 2-year wait. So I said, what about my patients who don't have Ehlers Danlos, but let's say have a genetic optic atrophy, some other problem? Oh, we'll see those pretty quickly. So why are the Ehlers Danlos patients second-class citizens? Because there's too many of them, I guess. I don't know. I didn't ask because they were much more forthcoming. I'm not going to complain. They're lovely people. They're very busy. There are only a few of them. And I can believe that probably one of the problems is that as people are becoming more and more aware about Ehlers Danlos, they're being forced to, there's a glut of people in the system trying to find out, do I have this crazy condition or not? And so the geneticists are getting killed. So I don't blame them for having a 2-year wait. Claire Francomano is a 2-year wait because people want to see her. But at least they're seeing people, I hope Hopkins has changed his policy, but now I pray it will. They're lovely people. The geneticists, they're among the best in the world. But like I said, there's only so many of them, and they only have so much bandwidth. At any rate, so if you find yourself a doctor who's willing to be an advocate for you, that doctor and you could try to find and build a network together. And even if the doctor that doctor sends you to is not, again, Ehlers Danlos aware, as long as they're not Ehlers Danlos antagonistic, I think you have a good chance of working with somebody. But you're right, it takes a village. Just like with a concussion patient, just like with a cancer patient, it takes a village to treat a patient with complex medical problems that have protein manifestations of the entire body. That's just the way it is. It's a rough hand to be dealt, but that's how it is. And I think that, me personally, I think that at least hooking up with a lawyer who has experience with Ehlers Danlos on the first go around of applying is probably not a bad idea. Because and the other thing is that in terms of your medical records, this is where you have power. Don't give up that power. Most places now have electronic medical records, and those electronic records have portals, MyChart, whatever you want, different portals. You're allowed to speak to your doctor through that portal. Anything you tell that doctor in the portal becomes part of your record and can be drawn off. So if you say, doctor, I'm feeling like this, my head or blah, 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 Your doctor should not think, oh, what a pain this patient is, what a nudge. No, your doctor should be saying, oh, good, this patient's giving me all sorts of useful information that I can put down. That's part of the chart. So that's something that you can use to empower yourself as well. You can upload things. You can say, hey, what about this? We had a patient before. I don't know whether, Ehlers Danlos patients have nutritional problems, often because of mast cell and stomach problems. Well, nutritional problems lead to whole other worlds of other problems. So when I have an Ehlers Danlos patient who comes to me with vitamin D deficiency, is that just because people have vitamin D, or is that the Ehlers Danlos? I don't know. We weren't even sure in writing the book how far to go with epiphenomenon of Ehlers Danlos. All right, so that book was actually a work in progress. I expect that book to be rewritten. I hope it will be rewritten in about 5 to 7 years at most, because I can't believe that the tons of information coming on about Ehlers Danlos is going to allow the information in that book to be static. That's something, again, you can do. I wouldn't start asking for a new NASM report today, but in about 5 years out, if you go through the NASM report and you say, wait a second, some of these things look a little dated, you're allowed to speak to your congressman and your senator and your representative and say, this is dated material. It was a good idea at the time, but it's not giving me the kind of help I need. I know for a fact that there's stuff that's not there that should be there. And that's another thing that you have as empowering you. The fact that the Ehlers Danlos patients have become a community is empowering of itself. Don't lose that. I'm not saying that, there are multiple Ehlers Danlos organizations. The Ehlers Danlos Society certainly is a powerful one. But whatever it is, let that community have a strong voice. And I think it's so important to notice, too, that everyone on this, that I can see here, all the participants are women. And I think that's very important. Because does that mean that Ehlers Danlos is X-linked? Does it affect? No, not necessarily. It means men oftentimes suck it up because that's what men do, or men don't think about it, or maybe maybe women get more worse Ehlers Danlos. Whatever the case is, though, that right now there's a big move to ensure that care is equitably provided, regardless of demographic. Okay? We know that women have gotten less good care than men have gotten, depending on the circumstances. This is time for women, if it's a community of women, to say, hey, wait a second, you're asking about women, here we are. We want the same quality care. We want the same quality respect. Okay, that's what we want too. I can't tell you how many times, with doctors and they have a patient who's a woman who with these complaints, and they're thinking, gee, maybe it's her menses. It's like, you've been there, okay? So it's not anything new to you, but this is something that it's a prejudice that hopefully will stop because it's people being more aware of it, with equity and justice and diversity and accessibility. And that brings me to the last thing I wanted to mention about this. The big move of diversity, equity, and inclusion is not just for the workplace, but it's also for healthcare. It's for everything. And the federal government and everyone else is recognizing there's another letter to DEI, and that's the letter A for accessibility. And what that means for you folks with Ehlers Danlos is that if you want to work, and you have a right to work, and there's work you can do, that accessibility has to be stuck there. And if you ever see people espousing the importance of DEI, and they don't put an A at the end of that DEI to make DIA, you tell them you're incomplete. You tell them you're missing the boat. You tell them that you're too narrowly focused on whether it's gender or skin color. You tell them you need to be focused on the whole person, and that includes accessibility. Because that's where Ehlers Danlos patients are going to get the support they need. to try to get back into the workforce and be as productive as possible within reason of their medical conditions. In terms of your medical records, you have a right to make sure your doctor puts in that record what you need to have in there. Now, if you don't know what you need to have in there, this is where you might speak with Ms. Bresnahan. Ms. Bresnahan, how would you like things worded? What would you think the best way to turn a phrase that would be most helpful to me? She's not going to tell you to lie. She's not going to tell you to put it to say. She's going to tell you, here's the truth, but this is a good way that Social Security would appreciate it be phrased. You know what I tell my patients when they need a letter of support or something? I tell them, write it. I tell them, you write that letter and send it to me in a Word file. I'll put it on letterhead. Oh, I'll edit it, maybe, make some changes, whatever. But you write the letter. And it's not because I'm lazy, although we all are, but it's not because I'm lazy. It's because of the fact that I know you better than anyone else knows you. You know your pains, you know your limitations, you know the dates that you got sick, you know this better than anybody. So when you write that letter and you have your lawyer look it over to make sure it does its job, it gets done faster. So even if your Ehlers Danlos doctor, even if your doctor is not an Ehlers Danlos pro, but the doctor wants to help you, if you make it easy for that doctor by giving him the work you need done, and he only does put on letterhead, how much faster do you think these things are going to turn around? That's another power that you have. So you can, when you're in your doctor's office and he's typing his notes in Epic or she's typing her notes in Epic, you have a right to say, could you please put this in there too? And they should, and they will. But this is, you got to be not afraid to ask. My patients are never rude, they're never pushy. They always ask nicely, and they always ask something reasonable. And I think it's reasonable. And if it's not reasonable, your doctor will tell you, look, I'm not sure about this. Then the least the doctor can do is say, there's a concern. Instead of saying, I'm 100% sure this patient XYZ, you can say, there is also a serious concern of XYZ. So at least the note reflects your thoughts. So these are some of the things you can do to make your records reflect you better. So when you go to someone like Ms. Bresnahan, she can say, whoa, this is really more helpful than the usual. I think we have a lot to work with here.
Wonderful. Now you guys can all see why Dr. Singman has been the inspiration for me putting together my book. He's a wonderful advocate, and I'd love to say that I was unique, but he's like this with many, almost all of his patients. He's incredible. So again, thanks for joining. As we talk about medical evidence, the recommendations are typical. Get copies of your own medical records, patient portals or formal requests. Sometimes, you might have to fill out forms and things like that, but getting your copies. And then, Ellen, what happens if we see something in our records that's either incorrect, or what does it mean when a doctor might put the term nervous in our medical records?
Yeah, you definitely want a doctor who's an advocate for you and that they believe you when you say you have tried as hard as you could to work as long as you could and you just can't do it anymore. And that's enough for the doctor. They're like, okay, I believe you and I will support you. That's ideal. When you don't have that, if your doctor tries to speak in code through your medical records, that they think this is kind of all in your head, you need a different doctor. That's a very strong statement coming from someone who's not a doctor, so take that with a grain of salt. But we have never seen a disability claim approved without a doctor who believes in you and will advocate for you. And look, a lot of times that comes down to the insurance company is going to call your doctor and say, hey, I'm Dr. Smith. I'm reviewing the records, for your patient. And I have some questions. And you want your doctor to communicate with the insurance company doctor and, you know, sort of walk them through why they think your, you know, your disability is supported. You know, with the code word of like mental and nervous condition in most disability policies. Now, this is not true of Social Security, but in most disability policies, that will limit your disability coverage to 2 years. The vast majority of policies will only cover mental health conditions for 2 years. So you want to, you know, be careful to keep that reference away from your records if that's not one of the things that's disabling you. You know, you can have anxiety, you can have depression, and they can on their own be disabling. But past 2 years, you have to also demonstrate that you have another physical condition that on its own is disabling for you. And the thing that we recommend, you know, in order, as Dr. Singman said, to get things into your medical record, we suggest that you keep a symptom tracker and a symptom journal. And you can do it every day of your life if you want. If that's, you know, too burdensome for you, you know, you want to kind of pick a period of time. Like, this is what a typical month looks like for me. This is a typical 3-month period, you know, whatever you are going to find possible. And you want to make sure that you record, you know, what your symptom is. You want to include the intensity of it and the duration of it and the impact that it's having on your functional capacity. You know, so if it's a day where, you know, you are not able to get out of bed, you want to put that. If it's a day where you were able to be up and functional, you know, for an hour or two, you want to say that. If you are able to be functional for a few hours, but then you crash and you have to go and lie down in order to recover, you want to have that documented. You know, you want to have documented that that's unpredictable. It's not like, you know, that from 9 to 11 every morning you're going to be able to work, and then at 11 you're going to need to take a 15-minute break, and then you can come back and work for another 3 hours. You know, that's not usually how it works for most people. So you want to record that it's, you know, I have good days and I have bad days. Here's what a typical good day looks like. Here's what a typical bad day looks like. And the more, if you keep that separate in, you know, a format that's easy to transmit to your doctor, you know, then you can give it and just say to her, you know, hey, this is what I've been keeping track of. I want to share it with you. If you have any comment, the best comment that your doctor can make is, you know, I've read your symptom journal, and I find it entirely credible. It is, you know, very consistent with, you know, the test results that I see, you know, with what I know of Ehlers Danlos, and what I know of you. You know, I find you to be a credible person who is trying their hardest to get back to work. You know, any comment like that your doctor can put around your symptom journal is going to be helpful.
And I shared in the chat, I have a ton of blank editable, like Word templates that are different kind of trackers and symptom logs and all sorts of things that are good resources. So feel free to go there, any of you, and, you know, share with anyone. I'm a believer of knowledge is power. And when you put something together and you gather resources, then you share it out. So for my next question, you know, as we talk about medical records and, you know, your doctor's comments, you know, there's also like the evidence and the tests. You know, for example, if you have dysautonomia or POTS, you know, kind of the gold standard is that you know, get a tilt table test. And, you know, there's specific measurements that you know, your change in your heart rate went, you know, 30 beats higher, you know, after standing X amount of time. And so, you know, it's a little more cut and dry with say POTS. Dr. Singman, you know, are there any, you know, measures or metrics or tests or things besides like the Beighton score? What else can we do in terms of that for EDS or other comorbidities?
Yeah. I wish there were a tool called a painometer that could somehow measure, put on your forehead and has a little dial to bring up how much pain you're in. That would make life so much easier for us, because you're right, the metrics are hard to come by. So as the example I mentioned earlier, someone has a regular MRI, lying down, everything's fine, you look great, compared to an upright MRI with flexion and extension, neutral, looking at different important metrics. Sometimes it's a matter of knowing what metrics to use and finding someone who uses those metrics. Other times you are actually left at the other extreme with subjective patient reports. And that makes things difficult, because a subjective patient report is a he said, she said kind of thing, where Social Security might very well say, I believe you, sure, you're a nice person, but I can't, what am I saying? Everyone says they're in pain. From my perspective, again, because I'm coming at it as a neuro-ophthalmologist, from my perspective, there are some things that I do measure, and I don't even bother telling the patient why. I just say, we're going to take a look, I measure convergence and pursuits and saccades and stereoscopic vision. And I look at the patient's facial responses. I look at the patient's way they handle the test. And I will put in my chart that my observation, okay, this is now objective, the patient clearly gotten sick, nauseous, dizzy appearing from my testing. So that's important, that's one of the reasons why I do my own testing, not my technicians do it. My technicians could do these measurements too. But the fact of it is, I'm not going to be able to see the response of the patients when they do those measurements. And that's not going to help me build a report that can be an advocate for the patient. It's interesting, you mentioned something earlier when your doctor puts nervous or something like that in your chart. First, feel free to challenge it. Say, what do you mean nervous? You can't read minds. How do you know I'm nervous? Oh, did I appear nervous? What did I look like that made you put nervous? Was my hand shaking? Was I diaphoretic? Was I sweating? Were my pupils big? I seemed to have a dry mouth. I kept asking for water. What is it that made you say I felt nervous? Because that's a judgment. And if that's a judgment, that shouldn't be in your chart, doctor. Okay, that shouldn't be your chart. If you want to say I'm diaphoretic, I'm sweating, that's an objective finding, sure. If you want to say I have a tremor, sure, that's fine. You can put it in your chart. Anything you want, but it has to be objective. If you're going to make an evaluative judgment of my behavior or my mental state, etc., feel free to ask me first. I'm happy to respond. So if you say, hey, Christie, are you nervous today? You say, thank you for asking Dr. XYZ. I'm not nervous, but I'm just really tired today, and I'm feeling kind of anxious lately. I've been kind of depressed, and I'm perfectly happy for you to put those in the chart. But thank you for asking, so that you avoid making evaluative judgment that can somehow tint the glasses that through which others look at me. So that's something that you have a right to do that.
Yeah, I appreciate you saying that, because many of us, it can be like often traumatic to go from doctor to doctor and be dismissed and discounted, and then you find someone like you, Dr. Singman, and it can throw us off our game, because it's someone that's listening to us and hearing us for the first time, and I think I fell down crying in your office the first time I was there. And, I know a lot of other people have that same experience with, like the Francomanos or the Hendersons, or, a lot of the people in the community who, understand this. And so, a doctor going experience is something that you need to plan for. And, I try to treat it like, I have an agenda. I'm going in to see this expert, and these are the, top 3 things that I need to kind of get out of this. I need to make sure to ask these questions. I need to prepare, because I want to use that small window of time that insurance allows me to be with you to my maximum benefit. And then for your notes on that visit to reflect, what's going on with me. So this is great advice.
The other thing is, I just want to mention that if your doctor says you only have a small window of time and that's it, get a different doctor. What I mean by that, honestly, is that I give my patients my email and my cell phone number, and I promise you, I do not get bombarded with calls, and I do not get harassed. I use that visit to take measurements that I have to do in person. And I tell my patients, you're going to have 1,000 questions. I want to answer every single one of them. But questions we can answer by email, through the portal, by talking with each other on the phone. So I try to use the time, that window that the insurance gives us to FaceTime, but that window is a window that that window is not the be all end all of that relationship. If it is, then your doctor's not doing the job. Now, some doctors say, okay, well, listen, I'll be able to talk to you more, but I'm going to start, charging telehealth. And if you have a 45-minute conversation with the doctor, that's probably a reasonable thing to do. But if it's just an email saying, hey, doc, I thought about this. What do you think? That's kind of his or her job, to discuss things with patients. And sometimes patients have a long list of questions. Okay, let's do this. Send me the questions in chunks that I can answer in a reasonable way, because sometimes some of the answers to the first questions help eliminate the later questions anyway. So I think, Christie, you're absolutely correct. Come in there prepared. And a lot of my patients come in with a big chip on their shoulders, like, okay, how are you going to dismiss me today? And I've had patients just let me have it, saying, I'm just tired of you, doctor. I say, well, what are you saying? Let's, vent. Feel free to vent. And now let's see what we can do as a team together. And it actually becomes quite enjoyable. It actually becomes quite, the reason someone becomes a doctor is, unless you become a radiologist or a surgeon because your patients are either, pictures of people are sleeping. If you actually become a physician to see patients, you should will it with people. But I think the preparation you mentioned, Christie, is critical.
Absolutely. So let's turn and ask Ellen a few questions about, so if someone is maybe still working or at whatever phase they're in and they're considering, filing for disability, whether it's short-term, long-term, Social Security, just kind of, in a vague way staying, what might you tell a potential client coming in? And the second part of my question is it advantageous to come in sort of before you do this initial filing, or is the time to see an attorney like after your appeal is denied? So I realize that's a lot of information, but
well, actually a lot of it we've covered already. Is what to think about. What are your medical records going to say to the insurance company? And if we have people, I'm sure that there'll be a way to get in touch with me afterwards. But
yes,
we have some free guides that we will give people of sort of general information how to apply for disability benefits, because there are certain things in common to every application. You need to have a supportive doctor. You need to have the narrative of why you can't, what your job duties are, and why you can't do them. And then for, and some people, that's all they need. They're like, okay, I got it. I know what my medical records say. I know what my policy says. I know how this is going to go. And at the end of the day, all you can do is submit an application and see what happens. The insurance company will either say, yes, benefits approved, or no, they're denied. When they're denied, they'll tell you why. And that gives you a whole lot more information to work with in order to appeal. We do have, for some people who are I'm just not sure and I would like to talk to a lawyer. We offer a flat fee consultation at $600 because it's a lot of work for us. But we'll get a copy of your policy. Policies are like fingerprints. There are a lot of things in common to all of them, but everyone is different. What they say about, pre-existing conditions, what they say about subjective symptoms, how long, whether there's coverage for them, whether they're excluded conditions, all sorts of things. So we can't advise you specifically about your claim without digging into your policy. And then we'll get copies, whatever you want to send us of your medical records. Usually you want to go back about 6 months to, here's the story the insurance company is going to be looking at. And then we'll get on a call with you after we've had a chance to digest all that. We'll get on a call, sort of walk you through like, all right, these are the, strengths of your claim. These are, areas where we think the insurance company might dig in, and then we'll help you with the application forms, which, there really isn't a lot of secrets to that. It's just, they're pretty straightforward, but you want to make sure that they're answering the question of why can't you work? What do you have to do for your job that you're not able to do anymore? And are your medical records going to support that?
Yeah, I know in my own personal instance, when all of this first happened, it was, post a motor vehicle accident, and, it set off cranial cervical instability and, POTS and blah, blah, blah. And, I had a sedentary job and I couldn't sit upright because, blood wasn't flowing to my brain. And so when I went to ask my employer for accommodations, they suggested I get a cot in my office. And so it's really an education process of patients learning how to use their communication skills to work with their doctors and with their attorneys to be able to sort of put together, this package, if you will, of, trying to make your own case. And a lot of people that have EDS, are in a situation where they're fighting all the time. They're fighting to get diagnosis. They're fighting for their health care, or they're on waiting lists where they're, it can be a really arduous process. So having an attorney on your side is a huge benefit, because it's someone else that can sort of, fight this fight with you. And, it's a good fight. And I've gotten a lot of information from Ben Glass Law. A lot of it is included in the book, and he does have a lot of great resources. And so I suggest that you check it out and read it. I put it in the website, in the chat. So Ellen, tell us a little bit about kind of the, uncomfortable question in the room is, how does the cost rate structure typically work with an attorney? And, state whatever you're comfortable stating.
Yeah, sure. Every firm is different. So I can speak to our firm. We don't handle Social Security cases, but we have referral partners, that we can send people to. Brian Gillette and David Ash are the two that we refer to. And they collect when they're successful on the appeal. So nobody needs a lawyer in order to apply for disability benefits, either with the insurance company or with Social Security. It's just a question of, here are my records. If you want to talk to an attorney and ahead of time, I told you what our consultation structure is like, that's never a bad idea. But if you apply and your claim is denied by Social Security or your insurance company, you have to have a lawyer. Like, practically speaking, I think it's possible to do it without, but it's just the deck is stacked against you. You're just thrust into this completely different world, and it's like we'll review your denial letter for free because we don't think it's fair that everybody whose claim is denied, ends up thrust into the, I need a lawyer world. Then for Social Security, if you're awarded benefits, the fee for the attorney is capped at, I think it's 25% of the back benefits that are awarded, to a maximum of, I think it's $5,000 or $6,000. It changes every year. I'm not sure. Ironically, if you have long-term disability insurance, the long-term insurance company will pay that fee for you, because in almost all cases, what they pay for their long-term disability is reduced by what you collect for Social Security. So they're very happy to help you get approved for that. And many times, even as they are denying your claim for long-term disability insurance. It's crazy. But when we feel, we only take appeals where we feel like there is a legal argument to be made about why the insurance company denied your claim. If they denied it simply because they didn't have enough information, we try to help you for free, figure out how you need to get that information. But if they are saying, well, your symptoms are subjective and so you're fine, that's where we come in, because we can point to a whole body of case law that says, no, for conditions that are not objectively verifiable, there is no test for Ehlers Danlos syndrome, that will check, yes, you have this. If it's not possible to objectively verify your diagnosis, then subjective symptoms become that sort of objective evidence that the insurance company is required to consider, unless the policy specifically says we don't cover these subjective symptom conditions, which a few do, but not all. They do have to consider what subjective evidence is. A lot of times pre-existing conditions, we can make a legal argument there about why the insurance company has reached too far to connect something that is disabling you now to something that you had treatment for, back in their pre-existing condition timeframe. So if we are able to make that legal argument, we've eliminated our upfront fees. Some law firms do charge upfront fees. Our fee is a third of whatever we're able to recover from the insurance company. Which it's a mental shift, right? Because if you are thinking of, I have this 100% benefit, I've been counting on it, this was my plan. And now to hear that, a third of it is going to go to pay your attorney, that's horrifying for a lot of people. And we get that, but the shift is that, no, once your claim is denied, your benefit is actually zero. And so we can help you recover up to 2/3 of it. And our fee is the same no matter what your benefit amount is. And that's sort of how it's sort of like that group insurance, like everybody pays according, a little communist, maybe, but everybody pays according to what they have. And if your benefit amount is low, we don't care. If your benefit amount is high, ironically, those are often the cases that we have to do the most work for, because the insurance company fights those tooth and nail. So we end up going, if your appeal is denied, the only next step is to file a lawsuit in most cases. Or even in Social Security, there can be litigation involved. So that's a whole story unto itself of how those cases go. But yeah, that's how our firm does it.
Well, terrific. Well, I know we're coming to the end of our time together. And, again, I want to thank you, Ellen and Dr. Singman, for joining us today, and everyone that's on here. And I know this will be replayed in the recording. I'm also going to share all of these fantastic resources that have been in the chat. Is there anything else that you guys would like to share? And unfortunately, I don't think we have any time to take any Q&A, because I don't want to disrespect your Sunday evening. But anything else you guys would like to share?
I think ours, www.benglasslaw.com. We have a chat feature on there. If anybody has questions they'd like to ask me, I'm happy to answer them through that.
Great, thank you.
And ericsingman@gmail.com. Feel free to email me.
He's wonderful. Yeah. All right. Well, thank you, everyone. Thank you for all the people who joined. It's been a really incredible week of EDS Empower Hours with, physical therapists. Friday, we had Dr. Alyssa Singman, who's, an EDSer herself, who's treating patients and to look at disability. So I'm really thrilled to be able to do this and, share any knowledge that I have that I've gained over the years making this journey. And it's too hard, and it shouldn't be this hard. And so if this is my little way that I can bring people together to share knowledge, I want to keep doing it. So thank all of you for participating. And look forward to hopefully seeing you again soon.
Take
Thank
care.
you.
God bless.
Thank you.
Bye.